circulating volume, but we can also consider other causes such as heart failure or sepsis. If the SBP on admission is less than 90, we should give 1 pint normal saline solution in bolus over 10 to 15 minutes and repeat back the BP. If the BP remains less than 90, we should repeat the 1 pint bolus And if repeated BP shows less than 90, we can consider colloids such as gelafandine. And if the repeated BP after bolus is more than 90, we can give 1 liter normal saline over the next 1 minute so not bolus. Okay. If the SBP on admission is more than 90, then we straight away start the DKA regime, 1 liter normal saline in first hour, and then we continue the next liter in 2 hours, then continue the next liter in 4 hours, and next liter in 6 to 8 hours. The first liter is normal saline saja, and then the next liters should be added on with potassium chloride Okay, so the rate of hydration should be guided by hemodynamic status, the state of hydration of the patient, serum electrolyte levels, and also the urinary output. So we need to monitor And more cautious fluid placement indicated in patients younger than 18 years, elderly patients, patients who are pregnant, and patients who have existing heart or renal failure. So in these patients, in the ideal setting should be managed in ICU Okay, next is correction of electrolyte imbalance. The most important is potassium correction because we want to give insulin, so we need to correct the potassium We maintain the serum potassium between 4 to 5 liters, and we should withhold potassium replacement in case there is no urine output So in our setting, in our hospital, usually the added potassium per pint of normal saline is like this If less than 3.5, we fast correct 2 gram kcl. If 3 to 3.4, we give 2 gram kcl in each pint. If 3.5 to 4.4, 1.5 gram kcl. If 4.5 to 5, we give 1 gram kcl. And more than 5, we only give 0.5 or withhold
Farhanah.
Hello.
Farhanah. Just now awak cakap pasal patient bergaum.
Tak dengar. Doktor, sorry, tak dengar.
Tak dengar?
Hello.
Hello, dengar tak?
Dah dia cakap dah.
Tak dengar.
Oh, kat sini. Okay.
Dengar tak?
Hello, doktor.
Hello, dengar tak?
Oh, dengar tapi slow.
Jauh.
Okay. Dengar doktor.
Hello.
Hello.
Dengar tak?
Dengar doktor.
Aku nak tanya just now you mention pasal yang macam elderly, yang group yang you kena fluid, dia kena cautious kan. Terus sama you mention pasal kena admit ICU kan.
Betul doktor.
Level apa yang kita boleh dekat emergency, apa yang kita boleh utilize untuk help kita punya management for DKA patient yang dalam special group ni
Dekat ED
sebelum masuk ICU patient takkan straight away pergi ICU kan, kadang-kadang satu hari masuk kan. So
kita boleh PO patient ke critical bay boleh doktor?
Okay, PO lepas tu orang kat critical nak apa? Orang ED juga kan tu, critical.
Betul.
Ha. Mungkin ni nak decide nak bagi tu apa yang awak boleh guna.
Sorry doktor, apa yang kita boleh?
Apa yang kita boleh utilize untuk kita decide nak bagi fluid banyak mana untuk patient-patient yang
Kita boleh guna our scan machine untuk
boleh check apa?
IVC flexibility lah untuk patient.
Kita boleh buat fokus untuk heart kan, tengok dia punya contractility, dia boleh include lagi tak dengan fluid. So we still have modality lah untuk treat this kind of patient lah yang dalam special group ni. Jangan just stop because of patient ni ada renal failure, ESRF, so kita pun tak boleh bagi fluid lah. Basically you boleh check IVC dulu kat mana tahu dia memang collapsible, kalau dia memang ada muntah, dia memang ada muntah-muntah tu sebenarnya memang dia akan ada volume kan. So some to help your affect your management. So tak apa pun.
Okay, so tadi kita stop dekat potassium correction. So okay, one other important aspect is fluid maintenance lah untuk patient in DKA. So apart from the DKA regime, we also need to give the fluid maintenance lah via Y system. Y system ni meaning patient datang je patient DKA, we need to insert 2 large bore branula lah. One for DKA regime and one for maintenance. So usually we give 6 pints normal saline over 24 hours, but the fluid may change according to the DST level of the patient lah. Okay, which will be presented later. Okay, then we start the insulin therapy. For DKA management, we start fixed rate IV insulin infusion. The rate is 0.1 unit per kilogram per hour based on the estimate weight of the patient. And we should delay the insulin infusion if the initial potassium is less than 3.5 lah, until we correct the serum potassium first. Then only we start the insulin infusion lah, because the insulin will increase the uptake of potassium into the cells. So takut nanti hypokalemia. Okay, then we monitor the DST hourly. If the glucose doesn't fall at least 3 millimoles per liter per hour in the first 2 to 3 hours, despite our adequate hydration, we need to increase the fixed IV insulin rate by 1 unit per hour. Once the plasma glucose already falls below 14, we need to switch to D5 lah and reduce the insulin infusion rate by 50%. Okay, so within 24 hours, usually we don't let the DST fall below 14 lah. But then after 24 hours, we need to maintain plasma glucose at 8 to 12 millimoles per liter. Okay, next is correction of... Ya,
Stop set. Okay, saya nak tanya lah semua yang ada dalam ni, Housemen, okay. Siapa boleh bagi tahu kenapa insulin infusion is very important in DKA? Izzah Nazrina. Kenapa kena bagi insulin ni, insulin infusion ni? Kita bagi awal lah, kita bagi. Kalau patient kita dah diagnose DKA, terus start insulin infusion. Kenapa? Yang lain boleh terajuk bukan Izzah saja. Siapa nak ramai sampai 20 orang. Just sajalah.
Tak dengar siapa kena.
Tak dengar siapa kena. Tak dengar online lah. Hello? Dengar tak?
Saya dengar tu.
Hang seorang dia kena mana? Ada orang lain. Tapi ada tolong buktikan kehadiran anda. Ada tu virus, okey. Tolong buktikan kehadiran anda. Setakat pakai nama. Bukan kamera. You all ni ada ke tak? Satu lagi yang present ada. Cepat, siapa yang ada ni? Ada nama banyak. Atira. Takut rebound. Apa maksud rebound tu? Prevent ketoacidosis. Okey, betul. Iza Nazrina. Betul lah, prevent ketoacidosis. Sebabnya in DKA, as we know, DKA ni usually occur in type 1 punya patient lah. Ataupun type 2 yang dah lama sangat, yang memang uncontrolled punya DM, yang basically insulin dia pun dah memang depleted lah. Okay, so disebabkan tak ada insulin ni, badan akan start decrease ketone bodies lah. Okay, so bila kita start insulin actually inhibit this breakdown of fatty acid lah. Jadi kita boleh stop the ketone bodies punya production untuk avoid acidosis to worsen lah. So we have to start insulin early lah, as soon as possible. Okay, dengar tak?
Dengar betul.
Sorry lah kalau dengar benda. Saya punya komputer bunyi bising. Okay, boleh continue?
Okay. Okay. So next is correction of electrolyte imbalance. Next, tadi kita cakap pasal potassium. Next is bicarb. It can be considered if pH is persistently less than 6.9 lah, despite adequate hydration and insulin treatment. And usually we give 100 cc in ni lah, 1 ampule in 100 cc normal saline bicarb. And then phosphate, there is no evidence to support routine phosphate replacement for DKA, tapi kita boleh consider if the levels is less than 0.32 lah, in presence of cardiac dysfunction or respiratory depression. Okay, then we need to monitor DXT hourly until it reaches maintenance level, as mentioned, 8 to 12 millimoles per liter. Then we can monitor 2 to 4 hourly. Vital signs and input-output charting hourly. And then we can repeat the venous bicarb and potassium at 60 minutes, 4 hours and 6 hours, which is from the VBG lah. Then we can send formal 6 hourly BUS and blood or urine ketones to monitor the drop and also monitor the electrolytes lah. If the ketones and glucose are not falling as expected, we need to check the insulin infusion pump if it's working and connected, and check the correct insulin residue volume lah in the pump. And then if the equipments are working but the response is still inadequate, we need to increase insulin infusion rate by 1 unit per hour until the target is achieved lah. Nampak ada ni. The resolution of DKA is defined as pH more than 7.3 and also plasma ketone less than 0.6 millimole per liter lah. Okay, so this is the summary lah of the management for DKA. As I presented earlier lah, the IV fluids, which can be divided into hypotensive and less than 90 millimeter mercury in SBP, and also more than 90, and insulin initiation, which is the rate 0.1 unit per kilogram per hour, and for the potassium supplement, and for the bicarb correction jugalah. So I think this is the end of my presentation. Anyone has any questions?
Iza Nazrina, ada 3 kriteria memang absolutely kena meet ke? Kalau ikut CPG dia memang N lah. Dia punya VBG, DST and also serum ketone ataupun urine ketone. Tapi kena tengok juga kadang-kadang patient yang dia muntah banyak. Dia akan hilang dia punya acid lah, proton kan, H plus tu. So dia akan jadi a little bit alkalosis lah. Dia tak obvious sangat dia punya acidosis tu. But still kalau dia pakai gut feeling jugalah. Kalau yang macam tu lah, macam dia punya pH 7.35 nampak macam normal tapi acidosis ada dia punya bicarb memang low. Then patient pun memang ada ketotic breath, then you boleh consider untuk treat lah. Okay. Hakim tanya patient yang DKA tapi fluid overload. Yang tu yang penting saya kata kena you kena guide your management tu dengan kita sekarang ada modality pakai ultrasound kan. Kita boleh guide kita punya fluid management tu lah. Try buat ultrasound, tengok IVC dengan dia punya heart contractility, cari B-lines ada ke tak. Kalau 100, 200 setengah dulu ke macam tu. Jangan bagi terus plan 1 liter. Okay, memang kena cautiously bagi fluid dengan keep repeating ultrasound lah. Check kita punya fokus apa yang kita cari pula. IVC dengan heart lah. And also lung punya ultrasound. And then another thing selalunya dekat dalam DKA ni memang kita boleh diagnose. Dekat dengar ke? Dengar lagi ke Farhanah? Tadi dia cakap apa? Okay, DKA ni memang kita boleh diagnose. Dekat ED ni kira kacang lah nak diagnose DKA kan. Tapi berapa ramai yang betul-betul attentif untuk cari what is the cause of DKA. Nah selalunya macam tu lah. Kita diagnose DKA tapi kita tak cari precipitating factor. Okay. Kadang-kadang patient tu sebenarnya dia tengah ada MI. MI pun can cause ni kan macam ni kata acute coronary syndrome. It can also cause DKA. That's basically infection lah. Yang selalu kita dapat kita kata DKA secondary to mismedication mostly. Tapi sebenarnya kalau korek-korek cari tengok patient ada perianal abscess lah, back carbuncle lah yang selalu yang dia tak declare dekat kita. So our
macam yang Dr. Husna cakap tadi, this is very important. DKA kena cari precipitating factor. The most common is infection. And kadang-kadang benda tu sangat obvious. Tapi sebab korang don't do the simple thing like tarik selimut. Recently we also have a very bad DKA young patient. Treat lah DKA. Ada source infection? Tak ada. Tapi tarik je selimut, sebenarnya kaki tu ada cellulitis. Tak ada orang tengok pun. Because satu patient tak complain about the leg and kita pun tak actively cari. Apatah lagi perianal abscess yang macam Dr. Husna cakap tu. Sah-sah lah korang tak pergi korek kat situ. So, be careful DKA kena cari precipitating factor. Most common infection. Okay, so memang kena cari focus of infection tu. Okay, sorry kata Ustaz.
Tak boleh. Macam tu lah. Jangan lupa mesti ada precipitating factor dia. Jarang-jarang macam means therapy tu kan lah. Tapi yang tu macam last lah. You nak tidur tak ambil treatment tu last kali lah. Cari dulu ada proses lah yang possible. Sebab kalau macam itu kita bagi
Hakim ada tanya dekat chat tu. Ada soalan Hakim dekat chat.
So kita treat patient overload dengan insulin sajalah. Kalau tak boleh bagi fluid, kita bagi apa yang ni lah. Macam insulin memang kena start lah. Kalau patient macam saya cakap, insulin actually stop the fatty acid punya breakdown to ketone bodies. Jadi kita nak stop dia punya acidosis. You can help by giving insulin infusion lah.
Yang Hakim punya ni, I think Hakim kena first bila cakap DKA tapi fluid overloaded, Hakim kena define fluid overload tu apa maksud fluid overload. By definition, patient DKA dia takkan fluid overload. So sebab fluid overload ni is a term yang semua orang guna, tapi it's just like a general term. Are you referring to patient tu, bila you kata patient tu fluid overload, patient tu ada fluid in the extravascular space ke? Contohnya macam dia ada hypoalbuminemia at the same time, dia ada chronic liver disease dan dia ada hypoalbuminemia. So all the fluid is in the third space, in the interstitium dan sebagainya. So DKA ni, bila kita bercakap pasal DKA dehydration ni, kita bercakap pasal intravascular volume depletion yang dalam vessel tu. You may have a patient, macam patient chronic liver disease with low albumin, intravascularly tak ada fluid. Dia dehydrated. Tapi clinically you tengok kaki bengkak, lungs wet. Lungs dia wet kan, dia ada cramps lah, ada pulmonary edema, ada ascites dan sebagainya. So kena clear. Sebab tu macam yang Dr. Husna cakap tadi, you kena rely on your parameters. Macam tengok IVC, because you nak assess intravascular volume. Keyword dia tu intravascular volume. We don't care about the extravascular punya volume ni dekat interstitium dan sebagainya. So we want to make sure patient ada adequate intravascular volume, because tak cukup intravascular volume then there'll be reduced perfusion to organs, to the kidney, which will lead to renal failure dan sebagainya. So jadi bila hakim tanya kita treat patient overload dengan insulin sahaja ni, kena define betul-betul apa maksud overload tu. Kalau macam overload as in fluid in the wrong space, tapi by assessment patient tu masih intravascularly under volume, you still kena bagi fluid. Okay, this is the time where you will see patient to manage fluid bagi, furosemide pun bagi. Or you kena treat lah dia, kalau dia ada nephrotic syndrome pun either you kena bagi albumin at the same time as ni. Tapi maksudnya benda ni dah di luar scope DKA lah. This is macam DKA in special situation, which is another lecture or course on its own lah. This macam dah bukan level yang macam kita boleh bagi general rule. This is yang kalau DKA with fluid overload, DKA with other medical condition, ni dah jadi macam special situation lah yang tak boleh di-generalizekan. Tapi secara prinsipnya DKA ni you need to replace the intravascular volume. Dan masalah kedua DKA yang semua orang tend to gloss over or tidak fokus adalah electrolyte imbalance. Okay, dalam DKA ni because there's such a lot of movement of fluid movement from different into from masuk keluar intravascular, extravascular, intracellular, extracellular. So you will have electrolyte imbalance. Maksudnya patient akan ada a lot of electrolytes akan shift, tukar daripada intracellular, extracellular. So benda ni pun kena pay attention. That's why kalau in pediatric apa semua, you tak boleh nak correct DKA cepat sangat, because then you will cause a lot of change in osmolarity tu cepat sangat. So fluid akan shift from one compartment to one compartment, and sometimes it will lead to benda-benda macam cerebral pontine myolysis dan sebagainya, or cause cerebral edema, which budak-budak kecil ni tend to be more sensitive. Orang tua you probably can get away, tapi budak-budak kadang-kadang perasan tak, kalau kita kat sini PITS jarang suruh kita start insulin infusion dan sebagainya, because they know we can't really monitor aggressively. Sebab one of the key things about DKA ni is monitoring. Memang kena monitor lah, literally stay by the patient punya bedside, hourly urine output dan sebagainya, which kita tak boleh buat, because we always get new patient coming in kan. That's why kalau you ikut standardnya, all this manage dekat ICU. Bukan sebab ventilatory support, sebab because of the intensive monitoring required. Tapi biasalah kita kat Malaysia ni sebab semua tak cukup kan. So all DKA ni should be managed in ICU or at least HDW punya settings, where there's 1 to 1 or 1 to 2 punya nursing, 2 to 1 punya nursing. Issue dia monitoring tu. Okay, so be aware. So ala-ala euglycemic DKA pun principal management yang sama. Tapi isu dia bila dalam euglycemic DKA, you're not too worried about fluid shift dan sebagainya sebab sugar dia normal. Tapi what you want to do is to stop the ketosis from ketogenesis by giving insulin lah. Tapi secara konsep dia sama je, monitoring apa semua. So sama macam DKA biasa pun, kalau you rasa dah adequately replace patient punya fluid, you still reduce the fluid correction dan sebagainya. So equalizer with DKA usually the acidosis tu yang problem rather than fluid punya cerita. Okay. Tapi euglycemic DKA first kena diagnose dululah euglycemic DKA. Itu yang selalu people have problems. DKA biasa ni senang. Euglycemic DKA ni yang semua orang kadang-kadang benda tu tidak berlegar-legar dalam minda lah. Tampak patient kenapa tiba-tiba ada acidosis je ni. And ketone, sugar okay. So DKA tu usually dah out of the window lah. So it's something that you need to keep in mind, especially kalau patient ada acidosis macam tak respon sangat to treatment. Kena consider lah benda tu. Okay. Serah balik kepada Husna.
Ada soalan lagi? Ada soalan lagi ke? Ke nak pergi next dah?